Good evening, everyone, and thank you so much for taking the time to be with me this evening. The purpose of tonight's webinar is to introduce you to a new field of medicine, um, explain a bit of the history, a bit of what it is, how it works, give you some examples of this type of medicine. Um, and then we'll take a quick break, following which I would like to discuss who's a good candidate for this type of work. And then finish up with a survey of the latest literature in the field on various joints and how they're treated and the success rate of what it is, what this new medicine can do for us. The new field is known as interventional orthopedics, and we'll discuss what that is in just a moment. What you need to know about me is that I am a medical doctor. Um, I did I got my medical degree downstate in Brooklyn, for those of you who know. If not, it's not terribly important. I did my fellowship at the Hospital for Special Surgery in Spine and Sports Medicine. I am triple board certified in sports medicine, physical medicine and rehabilitation, and in pain medicine. About 10 years ago, I came to the realization that what I was doing wasn't helping my patients. And I began to experiment with my patient's own repair cells. And I did a couple of procedures in some employees who worked in the office, and they did very, very well. And this reinforced my belief that this was a valid treatment modality and that I could help my patients by doing this. I have not looked back, and 10 years later, this is all that I do. So let me explain now exactly what that is. In 2005, physicians for the first time on Earth began treating orthopedic conditions using precise human repair cell injections. The first case report was published in 2006 by Centeno. A 64-year-old man with a 20-year history of hip pain and advanced hip osteoarthritis was treated with 2 injections of his own bone marrow concentrate, BMC, 1 month apart. And what they found was this. Before, there was no visible joint space. There looked to be a complete destruction of the cortex of the bone, the femoral head, rather. And following the 2 injections, this was the picture. There was suddenly a very thin joint line with what appeared to be neocortical formation. There was also an improvement in functional range, and there was an improvement in the range of motion and extension by 15 degrees. All of this was pretty eye-opening. What it represented was a new medical specialty, which has come to be known as interventional orthopedics. Well, everybody knows what orthopedics is. What is interventional orthopedics? Well, the best way to explain that is to compare it to traditional orthopedics. In traditional orthopedics, what we're doing is we're using scalpels, drills, and saws. And what we're doing is we're incising, cutting, grinding, amputating. We're placing screws, plates, rods, nails, anchors, staples, and sutures, a lot of hardware. The metaphor here is one of carpentry, compared to interventional, or otherwise known as regenerative orthopedics. We're using only needles and advanced imaging, ultrasound and fluoroscopy. There's no cutting involved here. What we're doing is we're injecting our patient's own blood or human repair cells. The metaphor here, what we're doing is we're delivering growth factors to damaged tissues. And the metaphor here with interventional orthopedics is gardening. In traditional orthopedics, we are removing and rearranging tissues. We are deconstructing and reconstructing tissues. We are replacing native structures. In interventional orthopedics, what we're trying to do is stimulate a repair and regrowth of native tissues. We are trying to preserve those native tissues. Why is this important? Because every surgeon in the world knows that preserving native structures is better than trying to replace them. The design of the human body is sublime. It has been refined over many thousands of years. And when you alter that design in surgery by replacing native structures or altering native structures, Whatever you gain in that surgery comes at a cost. Let's discuss the traditional algorithm of treatment in orthopedics. It starts with an injury. You step off a curb awkwardly, you twist your ankle. What do you do? Well, most of us know enough to put ice on it, maybe take some ibuprofen, wrap it up, elevate it. This is acute triage. And for most of us, in a day or two, we're getting back to normal. We may be hobbling a bit. But for those of us who aren't, we go to our private medical doctor and say, it's killing me. It's swollen. It's not working. Private medical doctor says, well, go see the physical therapist and writes a prescription. So you go to physical therapy, and those who haven't responded to date, the majority of them will respond with a little bit of physical therapy in time. But let's say you don't, and you go back to the private medical doctor, and he sends you to the orthopedic surgeon. And you see the orthopedic surgeon, or more likely you see the orthopedic physician assistant or medical assistant. And they say, well, let's try a steroid injection in that joint. And they do a steroid injection, and maybe this works. But after 2 weeks, the pain comes back, and you go back to the orthopedic surgeon, and the orthopedic surgeon orders an MRI. Now, if you're standing in an orthopedic's office and you're looking at an MRI, your chances for surgery go up about 90%. So let's say you have that surgery. Well, if you're one of the lucky few, that's all that ever needs to be done. But for a lot of folks, it's not the end of the road. And in another few years, you have another surgery on that joint. And then a lot of time goes by, and you go back to that same orthopedic surgery and say, you know what, it's still bothering me. And he looks at it and says, well, there's nothing else to do. It's time to replace that joint. This is the traditional algorithm of treatment in orthopedics today. What's wrong with it? Well, let's start with steroid injections. Steroid injections, and in the medical profession, and I speak not just for orthopedics, but for throughout the medical profession, we're just steroid crazy, steroid happy. We use steroids for almost everything. The problem with steroids is they're toxic. They kill almost everything they come in contact with. A study by McAllendon in 2017 published in the Journal of American Medical Association. It was a randomized clinical trial. They enrolled patients and they put them in one arm, the treatment arm versus the control arm. In the treatment arm, they injected a standard steroid, triamcinolone acetate, 40 milligrams into the knee joint every 3 months for 2 years. That's a total of 8 injections. The control group got an injection of sterile water every 3 months for 2 years. At the end of 2 years, they got an MRI. And what they found was that those knees treated with steroid had a 50% loss of cartilage. 50% loss of cartilage. What the steroid does is it kills the cells that are alive in cartilage. They're known as chondrocytes, and steroids kills them. In addition, steroids weakens ligaments. When I trained, the old rule was only 3 steroid injections into a joint lifetime. And that reflected the understanding that if you did it repeatedly, you would begin to get spontaneous rupture of ligaments. That was possible. So you didn't want to do that. Steroids lowers bone density. It makes your bones weaker and more subject to fracture. It raises your blood sugar, makes you more prone to diabetes. It suppresses your immune system and makes you more vulnerable to infection. It suppresses the adrenocortical axis in the body, causing weakness, fatigue, and depression. Bupivacaine and lidocaine, these are local anesthetics that are often mixed with the steroid that is injected. And these are, if anything, even more toxic than steroids. They kill chondrocytes, they kill fibrocytes, they kill tenocytes. These are the cells alive in cartilage, ligaments, and tendons in your body. What's wrong with the current algorithm? Meniscectomy. Meniscectomy is otherwise known as knee arthroscopy. It's otherwise known as, yeah, you got some arthritis in that knee. Let's go in there. We're going to clean it up for you. So this is the cleanup arthritis surgery. What they're doing here is they're cutting out hunks of the meniscus, which is a specialized cartilage that acts as a cushioning force within the knee. And when they see a tear in the meniscus, the orthopedic surgeon goes in this fashion with this procedure known as an arthroscopy and cuts out the meniscus until the tear can no longer be seen. This is a very, very bad idea, and the literature reflects that it is so. Because what happens is that within 8 years of this surgery, you have a 3-times increased risk of osteoarthritis in that joint. Why? Well, it only stands to reason. If you're cutting out the tissue that cushions the forces in the knee, what you're doing is you're increasing joint loading forces. And if you increase loading forces in any joint, what you're doing is you're rapidly accelerating the degeneration of that joint. So you get early arthritis after this clean up the arthritis arthroscopy. What's wrong with the current algorithm? Knee ligament repair. The anterior cruciate ligament, the ACL, is a ligament that runs from the back of the femur, which is your thigh bone, to the front of the tibia, which is your leg bone. It prevents the forward translation of the tibia on the femur. When you tear it, you cannot play sports at a high level, and professional athletes certainly cannot play. This ACL repair is a procedure that gets professional athletes back on the field of play, and it is a procedure that orthopedic surgeons are rightfully very proud of. Unfortunately, we've done it for long enough that we know that there's a big problem with it. We're not sure exactly why, but the assumption is that the repair, and this is an MRI of a repaired ACL. First of all, the ligament is not repaired. It is cut out and thrown in the wastebasket, and what you're getting is a replacement ligament that comes from a dead man or is harvested from another area of your body, like the patellar tendon right here. There's a hole that's drilled into the back of the femur and in the front of the tibia. A ligament is drawn through these two holes, and then screws are put in as anchors. You can see the screws here and here. Now, this gets you back on the field of play, but the problem with it is the angle of the ligament is now much steeper than the angle of the native ligament, which is much more horizontal. And we think that's the reason that within 10 years of this surgery, the knee is done. This is an article from the New York Times published in 2017 discussing the ACL repair rates in adolescent athletes. They stated that the incidence of this repair was soaring in these athletes. And Dr. Coker from Harvard was quoted as saying that 50% of these athletes will develop osteoarthritis within 10 years of this procedure. Think of that. You have a 15-year-old soccer player, tears his ACL, has an ACL repair, and if he's one of the 50% who will develop arthritis, at the age of 25, the knee is shot. Are you going to replace that knee? Certainly not. You've bought 20 years of pain and debility and activity restriction for that young athlete. The article ended by asking, will surgical techniques that more closely resemble native anatomy reduce the risk? And the answer to that is a resounding, you betcha. What's wrong with the current algorithm? Joint replacement. Joint replacement is another procedure that's really quite remarkable in preserving range of motion in a joint and allowing much more normal function. But there's problems with it. First of all, there's minimal functional improvement. Harding did a study in 2014 showing that only 1 in 20 achieved normal activity levels. That's 5%. Many patients are no more active after joint replacement, the study showed. Number 2, many patients complain of continued pain. Now, in the literature, as many as 50% of patients who undergo knee replacement in particular knee replacement, have the same or worse pain following the replacement than they did before the surgery. And then finally, number 3, there's a risk of metal and material fragmentation. This is a prosthesis. It's plastic and metal. And it's put in here, and after millions of flexions and extensions and weight bearings and standing up from chairs, and climbing stairs, you can develop wear particles from these materials. that can reach toxic levels in the blood. And then that's just a whole mess. And quite often it leads to having to revise the original joint replacement. And trust me, nobody ever wants to revise a joint replacement. You do it once, hopefully in a lifetime. What's wrong with the current algorithm? Spinal fusion. Spinal fusion destroys the motion segment. What's a motion segment? A motion segment is over here. It's this vertebrae, this vertebral body, and the disc that separates them. All of this is supposed to move independently. When you're doing this and placing screws that are attached to metal rods, what you've done is you've destroyed the motion segment, in this case of 1, 2, 3 motion segments in the lumbar spine here. What you've created is a block of bone, in essence. And the problem with that is it throws tremendous forces above and below that block. And what you run the risk of is developing transitional syndrome. The transitional level begins to break down, either above or below. And within 6 to 12 months, you're back in the surgeon's office and he says, whoops, up, we got to extend that fusion up a level, or oh, we have to extend that fusion down a level. And this is what's behind the saying that spinal fusion leads to more spinal fusion. And to add insult to injury, doing this fails to solve spine pain in an estimated minimum of 20% of patients. Now, that's quoted from the literature. As a spine specialist trained in fellowship in 2004, I'm here to tell you that that minimum is much higher. I would say it's well above 50%. So what is the promise of interventional orthopedics? The promise is that we use the body's ability to heal itself. All we're doing is taking our patient's repair cells, concentrating them, and placing them very precisely at the site of injury. It's minimally invasive because of this. We're just using needles through the skin. We're not cutting you open. And because it's minimally invasive, we are reducing, if not eliminating, operative trauma. And this considerably reduces your post-procedure recovery, and you have a less painful rehab. And when we are successful in doing this, what we have done is we have preserved the native tissue. We have not replaced any tissue in the body. And again, that's huge, because as good as we are at replacing joints, at repairing, quote unquote, the anterior cruciate ligament, at cleaning up the arthritis, what we've done is we have not replicated nature's design, because that's impossible to do. And you'll pay for that. The outcomes just won't be as good. This is a schematic of the healthy balancing act inside any joint in the body. You may have heard that you have a new skeleton every 7 years, and that's because that reflects a process where bone is being broken down and built up at the same moment. And ultimately, what you end up with is an entirely new skeleton. The same, it works for the articular cartilage in any joint in the body. It's continually being broken down and then built back up and repaired. And healthy joints, this is not even noticeable to you because you have no pain whatsoever. In unhealthy joints, what happens is the factors that are destroying the joint, catabolic factors, which is a fancy word for breakdown, and pro-inflammatory forces, are beginning to predominate. And then the joint becomes symptomatic. It starts to hurt you. It starts to bother you. Well, what are some of the forces that break down a joint? Well, injury, number one, first and foremost. And remember, surgery on a joint is a form of injury. It's a highly controlled form of injury, but it's a form of injury. And injury leads to instability, and instability leads to breakdown, and breakdown leads to pain and destruction of the joint. Obesity, carrying extra weight, particularly in the joints of the lower body. This is once again increasing the loading forces that joint sees, as we discussed earlier. And that, without a doubt, is going to, over time, accelerate the degeneration of your joint. Smoking. Add to all the bad things that you know smoking does, the fact that smoking destroys cartilage in the human body, destroys it. Poor diet, poor fitness levels, sedentary lifestyles. All of these things tip the balance here towards destruction. catabolic breakdown forces and pro-inflammatory forces, and the knee becomes arthritic and painful. So how do we counter forces and factors that break down a joint and cause chronic inflammation in a joint? How do we do that? Well, we use anti-catabolic, anti-breakdown forces. What are these? These are largely chemicals. They're chemicals that counteract the pro-inflammatory environment that is created inside an arthritic joint. These chemicals also inhibit the enzymes that are digesting your cartilage. They are known as MMPs, matrix metalloproteinases, and peptidases. Here are some examples of these chemicals. Interleukin receptor antagonist protein, IRAP, alpha-2 macroglobulin, A2M, TIMP, which is tissue inhibitor of metalloproteinase enzymes. These substances have only recently been discovered within the last 10 to 15 years. Where are they? They're inside your blood, your serum, the serum portion of the blood. These chemicals are all found there. So if you have a painful joint and you're able to get some of your serum and you injected that into the joint, you'd be doing a wonderfully marvelous thing by changing the pro-inflammatory environment and stopping these enzymes from digesting your joint. The other factor that we use are anabolic factors. Anabolic means buildup, as opposed to catabolic, which means break down. What are anabolic forces? In a word, these are growth hormones. These are not the growth hormones that you take to get a body like this. These are the growth hormones that every human being has inside their body. These are powerful cell signaling molecules. They promote cell division and growth. They increase vasculature. They stimulate protein and matrix secretion. Some of the names are PDGF, platelet-derived growth factor, fibroblast-derived growth factor, and vascular endothelial growth factor, VEGF. And to be clear, these growth factors are not the anabolic steroids, which is the only way you can get a physique that looks like this. Where do we find these factors that counter breakdown in joints? Well, as medical doctors, we find them in our patients. We are using our patients' autologous repair tissues. Autologous is a fancy word for self. These are our patients' own repair tissues. As medical doctors, we are manipulating them for use in musculoskeletal injury. Human repair cells come in two forms. One is a small circulating blood cell known as a platelet. You may have heard of platelet-rich plasma. That's what that is. The other is in adult stem cells. Now, stem cells in my world come from the bone marrow. Well, actually, it's another lecture entirely about where they come from. But trust me, they should come from bone marrow because bone marrow stem cells have a particular propensity to become the tissues of interest in orthopedics, which includes cartilage, ligaments, tendons, and bone. What do we call these repair tissues? We call them orthobiologics, and that's a conflation of the biological repair cells, repair tissues of our patients that we use to treat orthopedic injuries. Orthobiologics. That's the name that we apply to human repair tissues. Let's go back to this schematic now, and let's assume that you come into my office. Your joint is bothering you. And what that means is these catabolic and pro-inflammatory forces are beginning to predominate. And what I'm going to do is put my finger on the scale way over here and try to bump up the forces that build up the joint and that work against breakdown of the joint. So let's say you have some mild arthritis, nothing terrible, maybe a small tear in a ligament or a tendon. And I say, I think platelets can fix that for you. And we do a platelet-rich plasma injection. What are we doing when we do that? Well, we're getting a whole host of anti-catabolic factors from your human serum. And this is working against breakdown. In addition, we're getting at least one, if not several, powerful growth hormones, platelet-derived growth factor. And in many cases, that will solve the problem. But let's say you have a worse problem. Let's say your arthritis is worse. Let's say you have a ruptured ligament. Let's say you have a really badly torn tendon. And I'm going to say to you, this is a bone marrow procedure. Bone marrow aspirate concentrate. This is a stem cell procedure. What do we get with that? we get a whole host of powerful growth hormone, a whole bunch of them. And what we do by doing this is that we increase the factors that are going to restore this joint to health. Let's go back to the algorithm now. If you come to me in my office, the algorithm of treatment is identical up to the point of the MRI. Now, if you're standing in my office and I'm looking at the MRI, I may see something that I see that I can repair for you, and I will propose a regenerative orthobiologic injection. After I do that, I'm going to send you back to the physical therapist and give it some time, and hopefully in 8 to 12 weeks, you're feeling much better. And if you are, this is what we've done. We've gotten you back to health, back in the playing field. We have preserved your native tissue or joint. And look what we've done. We've taken you out of the algorithm that pushes you towards joint replacement, taken you completely out of it. We've taken a left turn. That's the promise of interventional orthopedics. What do we treat? Basically, we treat everything musculoskeletally. Headaches, neck pain, upper back pain, shoulder pain, wrist and hand and thumb pain. We treat low back pain, sciatica. We treat hip arthritis and labral tears, knee arthritis. What's this last one here? Oh, ankle arthritis, ligament and tendon tears. Here are some examples of interventional orthopedics. This is a picture of a setup that is very common in my OR. This is a fluoroscope, this thing. Here's the proximal end of it. There's a big curving C arm that comes around. This is the camera. It's sending a beam right through the knee. And this is the beam intensifier. And this is the picture that it's taking. And if you look really closely here, you can see that there's a trocar in the kneecap, which is known as the patella, and there's a very fine needle that's behind the kneecap, inside the knee joint, injecting some dye, showing the dye flowing behind the kneecap. This is an MRI slice of this same knee right here, and it's showing why we have to do this. You can see that the cartilage behind the kneecap is softening, and in the bone there is this white light. That's a bone lesion. That's a subchondral bone lesion that has to be treated. And so we're treating it by drilling into that bone, the kneecap, and we're going to deliver bone marrow into the kneecap, into the subchondral bone. The cartilage along the distal femur, the thigh bone, is completely worn away. And so what we're doing is we're bathing that in bone marrow aspirate concentrate as well. So it's a very complicated, very advanced image-driven technique of what we're doing. This is an injection of a superior labral tear, a slap lesion in a shoulder. The first placement shows injection into the glenohumeral joint. That's what this dark curving line of dye indicates. The second placement is into this area here. It creates a triangular dye pattern. That's the labrum. It shows you how precise the injection is. The next slide shows you even more precision here. This is a highly amplified ultrasound view of what we're doing by hydrodissecting the median nerve, which is right here. In other words, we are injecting all around the nerve some repair cells, in this case, platelet lysate. And this is how delicate this procedure is. This is done for carpal tunnel syndrome. This green sphere shows you the size of a pea. It shows you how delicate this work can be and how precise it is. Why will interventional orthopedics replace elective orthopedic surgery? Well, number one, it's less invasive, and that reduces recovery time quite dramatically, and rehabilitation. And when we're successful, what we're doing is preserving native tissues. We are not altering the native design of the human body. And again, that's key. That's key to a lifetime of happiness, as it were. Next, I would like to discuss who's a good candidate for this type of treatment. And how do we know who's a good candidate? Well, we have at least one very large patient registry. And what a registry is patients report into the registry how they do after these procedures. And we have a very large repository that's owned by Regenix, thousands of patients reporting at 1, 3, 6, 12 months and annually thereafter following these bone marrow and platelet procedures. And from this data, we can glean who's a good candidate, who does well and who doesn't do so well following these procedures, and perhaps why. Well, let's start with knee osteoarthritis. Now, this is a normal looking knee, and this, of course, is an arthritic looking knee. Who's a good candidate? Well, there's no correlation with age. And that's an interesting thing to note. Young people in general do better with these procedures just because they're younger. But ultimately, the outcomes in terms of avoiding surgery, there's no correlation with age. There's no correlation with radiographic severity. And I put in small parentheses here, up to a point. Yeah, there's a point of no return, and we'll discuss that in just a second with the next slide. There's no correlation with sex. Men don't do better than women or vice versa. And there is no correlation with body mass index, obesity, at least in the short run. Who's not a good candidate? Let me bring this down. This is always seemingly where I don't want it to be. Who's not a good knee candidate? Well, if you have two bad knees versus one, that's not necessarily a good prognostic indicator. But what's even worse is that if you have 3 or more surgeries on the joint, on the knee joint, that's a bad prognostic indicator. Also, if you have 3 or more joints that are impacted by arthritis, that are beginning to impair your functioning, that's also a bad sign. Or if there's gross malalignment of the knee. And here's a knee that's grossly malaligned. You see that the femur bone is sliding off the tibia. You come into my office, as routinely happens with a knee like this, or a hip like this, or a shoulder like this. I'm going to say, I'm terribly sorry. I cannot help you. Have the joint replaced. You'll be a happy camper. Let's discuss the latest literature. This is one of the seminal studies in the field of regenerative orthopedics. It's done by one of the godfathers of this field, a surgeon, an orthopedic surgeon named Ernigau. He's French, and this study was done with funding by the French government because it couldn't be done any other way. It's an extraordinary study. It is the highest level of evidence. It is a randomized clinical trial. What Ernigau did was enroll 140 patients who had similar bilateral knee arthritis. And what he did as a surgeon is that he replaced one of the knees surgically, and the other knee he injected with the patient's bone marrow aspirate concentrate. In other words, with the patient's own stem cells. And then he followed them for 15 years. That's right, 15 years. This is the type of study that couldn't be done without government support. And this is what he found. He found that after 15 years, the failure rate in the knees that had been replaced was exactly the same as the failure rate of those knees that had been injected with stem cells. 18%, 25 of the patients randomized to the bone marrow stem cell treatment arm went on to joint replacement, whereas 15% in the total knee replacement had to have a second surgery. In other words, the original replacement had to be replaced with a revision replacement. Now, I wasn't ready to leave that slide. The average time to a joint replacement in those knees that had been treated with a bone marrow injection was 10 years. Now, I'm often asked that. How long will this last, Doc, if it's successful? And my conservative response is always, I expect it to last 5 years or more. Now, here's randomized clinical trial, highest level of evidence that indicates that it can last 10 years on average, if not more. You see the incidence of failure was 1.19% versus 1%. Statistically, this is the same. The conclusion of the study was orthobiologic injection using stem cells had a sufficient effect on pain to postpone or avoid TKR, total joint replacement. This is a sister study that Ernigau did at the same time. This came out in 2021 as well. In this one, he wanted to answer the question, what's the best way to inject stem cells? Do you just put the stem cells inside the joint capsule? Or do you inject the stem cells in the subchondral bone, which means you have to drill into the bone beneath the chondra, underneath the cartilage, the subcartilage bone, and inject there. We have known for a long time that cartilage and subchondral bone, the bone beneath the cartilage, share a very special relationship. And if one is not healthy, the other is not healthy. And what we often find in advanced cases of arthritis is bone involvement, bone lesions just underneath the cartilage and the subchondral bone. And what Ernigau was trying to decide was, is it better to inject the subchondral bone or just inject the joint itself so that the cartilage or the areas of denuded bone that has no cartilage left is treated? So what he did was he took 60 patients, again, with the same bilateral knee osteoarthritis. One knee he injected with bone marrow into the capsule, into the joint. This is called the intra-articular, the IA group. The other knee, he injected the stem cells into the subchondral bone. This was known as the interosseous group, the IO group. And again, followed them for 15 years. And here's what he found. The replacement rate in the knees that were injected inside the joint was 5% a year. And over the course of 15 years, 70% of those patients went on to knee replacement. Compared to those knees that were injected into the bone, the rate of total knee replacement was 1% a year, much, much less. And that over 15 years, only 20%, less than a third of those, had to go on to joint replacement. The conclusion, implantation of stem cells in the subchondral bone of an osteoarthritic knee is more effective than injection into the joint to postpone total joint replacement. Since these studies came out in 21, I do bone augmentations on all advanced osteoarthritis cases in my office, all of them, based on these studies. It revolutionized what we do. Let's talk about hip joints. First of all, hip joints don't do as well as other joints, and we discovered this in the past 10 years. For some reason, they don't do as well. We don't really know why. You want to catch hip arthritis very early if you're going to change it. Stop it, keep a person away from joint replacement. So who's a good candidate here? A good candidate is somebody who's under the age of 55 with mild osteoarthritis, or with minimal osteoarthritis and a torn labrum. That's a good candidate. What do we mean when we say good? Well, we think when we say that you're a good candidate, we think that your chances of success are 60% or better. So in other words, every 10 times we try, we expect success at least 6 times. At least 6 times. That's a good candidate. Those are the odds of a good candidate. If you fall into the fair category, the criteria here is you're over the age of 55, quite simply, and your arthritis is more than moderate. You fall into the poor category if you're over the age of 55 and you have any loss of motion. Any loss of motion. And the first thing you lose is internal rotation, and that you lose even before you almost notice it. But when you come into my office, we can tell immediately. And if you fall into that category, you're not a good candidate for this. Here's a study published in 2022 comparing platelet-rich plasma versus hyaluronic acid in hip arthritis. Hyaluronic acid is the gel shot you may have heard about. This involved 105 patients. Again, this is the highest level of clinical evidence, randomized clinical trial. Patients were randomized to 3 treatment groups. One group of hips just got PRP injections alone. The second group of hips just got a gel shot alone. The third group got both PRP and the gel shot. Each group got 2 injections 2 weeks apart. Outcomes were measured at 2 and 6 months. This is what they found. The PRP and PRP plus gel shot groups did significantly better than hyaluronic acid alone. Not only did the treatment last longer, patients got better relief. And the upshot was there was no significant difference between the platelets alone and the platelets plus gel shot group, which tell us that it wasn't the gel shot that was doing much of anything beyond 2 months of relief. Shoulders, candidacy grades. Again, registry data indicates that there's no correlation between outcomes and age, sex, or bone or body mass index. In general, the word here in shoulders is severe arthritis can do well if most of the pain and debility is thought to come from the rotator cuff, which is this tissue that comes over the top of the shoulder and abducts the arm. You're a good candidate if the rotator cuff has a full thickness tear, but is non-retracted. And of course, all partial thickness tears. These are good candidates for what we do. Fair candidates are those rotator cuffs that are torn between 2 and 10 millimeters, in other words, less than a centimeter, and are not retracted. You fall into the poor category if you have a full thickness tear that is retracted more than 10 millimeters or more than 1 centimeter. And yet, having said that, here's a rotator cuff. You see it coming over the top, and all of a sudden there's a big hole in it, and this is the distal portion. This is a retracted rotator cuff, full thickness tear, more than 1 centimeter, treated with bone marrow. This is an exception to the rule. 6 months later, a repaired rotator cuff with the patient's own stem cells. There are exceptions to the rule. But if you have this and come into my office, I'll tell you, you're a poor candidate. Your chances are less than 30% for success. Shoulder arthritis candidacy grades. You're a good candidate if the arthritis is mild. You're a good candidate if the arthritis is moderate, but most of the pain is thought to be coming from the rotator cuff, because we can deal with rotator cuffs better than we can with shoulder arthritis. You're fair if the arthritis is severe, if the pain may or may not be mostly from the rotator cuff. You're a fair candidate at that point. You're a poor candidate if your shoulder looks like this. If the ball has become an egg shape and you have a huge osteophyte, this thing coming down here that we call a beard osteophyte, you're a poor candidate. You have less than a 30% chance to respond. Probably not a good idea for you to try this modality. Here's a study comparing platelet-rich plasma versus rotator cuff surgical repair for partial cuff tears. Again, highest level of evidence, 25 patients randomized to PRP, 20 to surgical repair, followed for 2 years. Here's what they found. The pre- and post-op scores in the surgery group were almost identical to that in the platelet group. Really no difference. The mean percentage of improvement, again, statistically, no significant difference between groups. But down here, let's go back, sorry. Down here, the mean time to recovery, significant difference. 4.6 months compared to 3.1 months. That's a significant difference. In other words, the people who got PRP fared just as well as those who got surgery, but they recovered much quicker than those who had surgery. Lumbar degenerative disc disease, DDD. If you have this, are you a good candidate for what I do? Well, you're a good candidate if you have even severe degenerative disc disease without severe stenosis. What's stenosis? That's narrowing that you see here. This is the spinal canal, this white area, and you see how narrow it gets in here. This is severe stenosis. What does stenosis mean? It means that you can't stand. People who have stenosis cannot tolerate standing. If you can't stand up to an hour with no pain, if you can stand up to an hour with no pain, you're a good candidate, even if you have severe degenerative disc disease, as is evidenced by this degenerated disc right here with bone lesions on either side of the disc. You're a poor candidate if you have severe degenerative disc disease with severe stenosis. In other words, you can't stand up to an hour. You can stand 10 to 15 minutes before you have to sit down. You're not a good candidate for what we do. Lumbar discogenic pain. What is discogenic pain? That's pain that doesn't allow you to tolerate sitting. Patients who can't sit for more than 15 to 30 minutes who come in with an MRI that looks like this. The disc is dark. It has a white annular tear at the back of the disc, but the disc height is preserved. The disc height here is about the same as here and here. If that's the case, you're a good candidate for what we do. This is a sweet spot. We excel in treating this type of back pain. You're a fair candidate if you have discogenic pain, in other words, can't sit 15 to 30 minutes, if you've lost some disc height, but not more than 50 to 75% of the disc height, and you have an annular tear, as seen right here. This disc is it's dark, it's thinned out a little bit, it's got an annular tear. You're a fair candidate for what we do. You're a poor candidate if you can't sit 15 to 20 minutes and you have more than 50% loss of disc height. That's a poor candidate. We're just not going to be able to get that disc pain to resolve for you, or not typically. Disc protrusion with leg pain. You're a good candidate if it's just a disc protrusion, extrusion, free fragment with preserved disc height, as is seen here. See how large that disc protrusion is? And you see how ugly it looks at cross-section here. But that's a good candidate for what we do. You're a fair candidate if that ligament is beneath, if that disc protrusion is beneath the ligament, as you can see tented up right here. Because when we inject into the epidural space, none of the repair cells are actually getting to the disc because of the ligament that's hiding it. You're a poor candidate if it's a hard disc. This is a bony disc associated with a bony ridge osteophyte. We're not going to be able to help you with that leg pain in that case. This is a systematic review published in 2023 comparing or looking at the use of platelet-rich plasma for low back pain. Now, notice they didn't even look at stem cells here. They were just looking at platelet-rich plasma. And this is really the best, most powerful study I could find for low back pain at this point. And what it was 13 randomized clinical trials, highest level of clinical evidence. 7 studies were looking at disc pain. 3 studies were looking at leg pain, sciatica. 2 were looking at arthritis in the spine, and 1 was looking at instability in the spine. Total of 914 patients. The conclusion of this review was that PRP was, in general, an effective and safe treatment for degenerative low back pain. Now, in my office, we treat a lot of spines, and we do it with not just platelets, but we treat discs with stem cells. And this happens to be one of the sweet spots in my practice. Some of the greatest successes I've had is treating a degenerative disc disease in the lumbar spine. People who've had crippling back pain for years come in if they fall into the fair to good category. We do treatment, and a good percentage of those have a remarkable outcome. And now that's just anecdotal, but I can tell you that's my experience, and I love to treat backs. Of course, I was trained in fellowship to treat backs, so I treat a lot of them. So we're just about done, 30,000-foot view. We're able to help many patients with severe arthritis avoid a knee replacement. Now, this doesn't work. It's not magic. We don't grow you a new knee. It works by making the toxic chemical environment in your knee healthier and by stimulating repair tissue. Mild arthritis, prevent it from getting worse, and we can treat knee meniscal tears. We're able to help many patients with chronic back and leg pain, other knee or joint ligament tears. I want to thank you for being so patient tonight. I'm sorry I went a little bit over. It was a lot of ground that we covered tonight. I hope that you feel a little more informed about this new field of medicine. And if it has provoked any interest in finding out whether you're a good candidate or not, I welcome you to contact my office and come in and see me. I am happy to answer any questions that anybody has. If you just type them into the chat box, and I will stay as long as anybody has questions. Let me say that the way my practice works is that we will see anybody under their insurance for an evaluation. We don't charge for evaluations. If you've never seen an orthopedic before, we will treat you just like any orthopedic in the country, up until the point where it looks like you might need surgery. It's at that point that I will, once again, explain to you what it is I can do for you short of surgery, and then give you an option if I think you're a good candidate. Looks like we have a question here. What bones do you get the stem cells from? How does it work? Painful, recovery time. Good question. As a medical doctor trained in getting bone marrow, I can, of course, get bone marrow from any bone in your body, but we get them from the iliac crest. Now, I unfortunately don't have a model of the ilium. The iliac crest are the two large bones that you feel if you run your hands down the sides of your torso down to your belt line. Those two bones there, those are called the ilium. If you work your hands around towards the back, those bones you can't really tell by touching back there, but they become thicker and wider. And it is in those two thick, widened areas on either side of the lumbar spine, which is right in the middle. That's where we get the bone marrow. Why? Because there's a lot of bone marrow there, a lot. And there's no major nerves or blood vessels we have to worry about. So the positioning here is that you come in, you lay down on your stomach. We sterilize your lower back and the top of your hips, which is where the ilium is. And then we spend the first 15 minutes of the procedure numbing you up. I start on the left side because I'm right-handed. I numb your skin, I numb the deeper subcutaneous tissues, and then most importantly, I numb the bone. And that's the key, numbing the bone. If you numb the bone, then you can drill into the bone, and it's not painful at all. I've personally had it done 4 times. I've done it hundreds, if not a couple thousand times in patients. It doesn't hurt. I know this is one of the main concerns of patients. Everybody, you hear, oh my gosh, he's going to my bone marrow to get bone marrow from me. It's got to hurt like stink. No, it doesn't. When you're properly prepared for this, all you feel is pressure. That's not true. When I aspirate the bone marrow, you feel that. It's kind of an icky feeling. Not terribly painful, but it's an icky feeling. It feels like somebody pulling something out of the deepest part of you, inside your bones. But I always ask patients, I rarely hear that it's more than 3 or 4 out of 10 intensity discomfort. And we do this in numerous places on both sides, because that's a technique where we get the highest concentration of your stem cells. So to answer your questions, that's where we get it. And is it painful? No. Recovery time, that's the least of it. Are you sore the next day where we harvest the bone marrow? Yeah, you are. But if we're doing a shoulder, the shoulder's a lot more painful than where we harvested the bone marrow, a lot more. You can't submerge in water for 72 hours because we have created an avenue from your skin going down into your bone all the way. You know, could be a bacterial highway if we don't protect you. So we cover it with an occlusive dressing, which doesn't allow any water to get there. But we don't want you to test that. So no submerging in water for a minimum of 72 hours. You can take a shower because the shower just rolls right over the occlusive dressing. It's not going to see any of the op site where we harvest the bone marrow. And then all bone will repair itself. The bone marrow starts replenishing itself immediately. We take bone marrow out, the body immediately starts making more. Body begins to immediately repair the bone. It's no big deal. That heals up in a couple weeks. That's no big deal at all. If we do bone marrow in your knee or your shoulder, it's a longer recovery. Um, Typically a week of stiffness, swelling, can't really move it all the way, can't bear full weight on it, push off. By about a month, we assume that you are back out of a brace, off of any crutches, working out fairly normally. Um, we expect you to begin physical therapy at that point. That's your first follow-up at 4 weeks, and I always order physical therapy at that time. Your second follow-up is at 3 months after we do this. Why? Because studies show that the first blip up in the data that says that pain is decreasing and that function is increasing is between 8 and 12 weeks after we do a bone marrow procedure. Now, it's quicker after a platelet procedure. It occurs more typically between 6 and 8 weeks after a platelet procedure. But the lag time is that what we're trying to do here for the long-term success of these procedures is to stimulate the growth and repair of tissues. That takes time. It takes time to do that. So we have to be patient. And being patient after these procedures is quite typically some of the hardest, things you have to do. The hardest parts of the procedure is to do that. We have more questions. Bernard asks, can you help with grade 1 L4 spondylolisthesis? Yes, that's a great question, Bernard. Or is it David? I'm sorry. I shouldn't even use names. Spondylolisthesis is the slippage of one vertebral body on another. They should line up, and when one doesn't and slips forward, we use a fancy term for that. It's called spondylolisthesis. And there are 4 grades of it. Grade 1 is the smallest. The answer is yes. We treat grade 1 routinely. We do a good job with treating grade 1. This modality works excellently for creating stability in spondylolisthesis. What we do is we inject all the ligaments that are still there holding these bones together. They include the intertransverse ligaments between the transverse processes, the interspinous ligaments between the spinous processes, the iliolumbar ligaments that connect the transverse processes to the ilium, that large hip bone we just talked about. All of these are precisely injected under a fluoroscope with feel and the injection of dye to prove that I'm actually in the ligament that I say I'm injecting. And what are we injecting? Typically, we're injecting your platelets. We can inject your bone marrow. It's much more expensive to inject your bone marrow, and quite often that's not necessary unless we have some reason to suspect that those ligaments are torn, as is the case if you get thrown from a motor vehicle at 80 miles an hour. Yeah, we may have to do something like that. Yeah, the short answer is we treat grade 1 spondylolisthesis quite commonly. I do, and have done it a lot for years in my office. Another question, can PRP injections be given in the spine to a patient who has a lumbar fusion? Yeah, absolutely they can. Yeah, absolutely. What we tend to do in that situation is we treat above and below the fusion construct. And then within the fusion construct, if there's more narrowing, lateral recess stenosis, we'll inject over a nerve that comes out of that construct. There's not much you can do with, stainless steel that's hardware that's holding everything together. There's not much you can do in between the vertebral bodies when they've shoved cadaveric bone or your bone morselized with bone morphogenic protein between them and caused a fusion. There's not much you can do. But yeah, no, we can inject in fusion. But really what we're doing with lumbar fusion is we're trying to prevent the breakdown of the transitional levels above and below the fusion level. And this is a very smart thing to do. The other smart thing to do, of course, is to maintain fitness level, maintain your core strength, the strength at the core of you. That's what you do in physical therapy. What I can do for you is strengthen the static stabilizers of the spine. You're working on the dynamic stabilizers, which are your muscles. But yeah, we inject into lumbar fusion again routinely in my office. Because we have to, because people with lumbar fusions don't do well with time. That's my experience. For a 3 centimeter supraspinatus tear, ortho advised reverse total shoulder. Is this better than a ATOIC for a 72-year-old swimmer, and golfer. Well, that's impossible to tell unless I examined you and looked at your studies. But in general, a 3 centimeter retraction on a supraspinatus is only going to be repaired surgically. I can't repair that for you. The question is that your main problem? Or is it generally instability? For example, what does the infraspinatus look like? Not just the supraspinatus. What does the teres major and minor look like? What does the subscapularis tendon look like? These are things that I, don't know until I evaluate you and look at your MRI and see what your range of motion is. But I hear you that you don't want a total joint replacement because a total joint replacement in the shoulder may prevent you from swimming and may prevent you from golfing. You may lose, you might gain rather quite a few strokes on your handicap after such a procedure. Does Medicare cover these procedures? No, they do not. Medicare does not cover these procedures. Most insurances don't cover these procedures. You have to understand that you're at the beginning of a new field of medicine. It only began in 2005, which seems like a long time ago now. It's 20 years, but that's the blink of an eye in medicine. And you have to understand that insurances are not covering these because, why would they want to cover another procedure? Number one. Number two, every insurance company in the world has emeritus orthopedic surgeons sitting on their advisory boards. And the majority of these surgeons are telling insurance companies, oh, don't cover that. That's experimental. The literature's not there on that. Don't cover those. Well, tonight, hopefully, I've shown you by quoting the literature to you, at least 4 studies, that the literature is not only there, it's robust. It shows that not only does this work, it works just as well as surgery, and in many cases, better than surgery. But that's what we're in the midst of. Insurances don't cover this routinely at all now. So how it works in my office is if I feel that you're a good candidate for this, I send you a proposal. And that proposal comes to you via email so you can peruse it on your own at home. And then if you have questions, you call and we talk it out. We don't haggle over money because we're not used car salesmen. We are medical doctors. We happen to be working outside of the insurance model of medicine at this point because we have to. But that's, no reason not to consider doing these. And I think you'll find that the price tag on these procedures is not the astronomical figures that you may have heard quoted. Mostly those astronomical figures are quoted by people who don't know what they're doing, who are just trying to separate you from your money. In other words, these people are participating in fraud. So be careful out there. There's a whole other lecture I do on fraud in this space, and I cut it out of tonight's lecture because it was long enough without it. Is all bone marrow from a person healthy enough to use? And if not, can donor marrow be used? No. All bone marrow, short of a raging cancer or, end of life positioning in terms of the patient, is adequate for what we do. Nobody anywhere in this country or in the world uses somebody else's bone marrow. That's verboten. It's very dangerous. It's not done. You may have heard that it's being done. Again, that's pretty much fraud. What we're hoping to get to is a place where we can actually extract stem cells from you, grow them in culture. Stem cells have no self-markers on them. So theoretically, we could get stem cells from anybody who wished to donate bone marrow, and we could create a vast tank of stem cells, which could go to anybody. Anybody. But in this country, Federal Code of Regulations does not allow that. It's a felony to inject a cell obtained from another human being into a separate human being. Now, there's a whole other lecture on the codes that regulate what we do, which I haven't gone into. I can, but it gets kind of thick and in the weeds legally. I can't even read this, Bernard. Anatomic versus reverse. I swimming golf a lot. You swim and you golf a lot. I get that. Okay. Only supraspinatus tear. I am currently swimming and golfing pain-free. Well, if it's retracted 3 centimeters, as you said, I can't help you. And if you can do all of that, you don't need repair on the supraspinatus, Bernard. Okay, you don't need it because if you can do all those high-level activities, the rest of your rotator cuff is compensating for what you have lost in the supraspinatus, which is only one strand of the rotator cuff. Any more questions? I've kept you for a long time. I appreciate all the time. I appreciate you coming out and spending some time with me tonight. If you'd like a copy of this, you can contact the office, and Patty will send you a link so that you can have it and review it at your leisure. If there are no more questions, I think we should conclude. All right, everybody, be healthy, be safe, and thank you again for the time.